So I was really happy to accept the invitation today and come and present about the OnTarget website. So this project is really important to me, so it's really a pleasure to be here today. I forgot my disclosure slide, so I don't have any conflicts specifically in regards of this project, but the OnTarget website was made possible with the persistent and support from the drug companies, and also with the support of Le GEOC. I use the AI for a certain slide, and you will be easily able to identify which ones. During the presentation today, I would like to explain where the OnTarget platform is coming from, and also to show you the content that you can access on the platform. We will then use a few patient cases to see how you can use it in your daily practice. So to explain where it's coming from, I would like to travel back in time and just ask a question first. Can any of you name what is the first commercialized targeted therapy that we had in oncology? And I'm going to give you a bonus point if you're able to give me the year. No. It even made the cover of the Time magazine back in the time. Dr. Miller, maybe? So actually, it was Glivec, almost 25 years on the dot, on May 10th, 2001, where it was granted FDA approval. And Glivec was actually the first drug that was able to demonstrate that by inhibiting a single molecular driver, we could dramatically change the course of a disease. Glivec was able to convert a once fatal disease into a now chronic, manageable disease. And this was really setting the bar really high for other contenders. At that time, also, Glivec was proving the concept of the oncogene addiction, and it paved the way to subsequent successes, such as HER2 therapy in breast cancer, EGFR inhibitors in lung cancer, and many others. So here, you have a graph of all the approvals that we had since that time, and you can see that the field really exploded over time with several approvals. And this was actually driven by the fact that over the last 25 years, we had the usage of the molecular diagnosis and also a better understanding of the tumor biology. And it did not stop there. We had new drugs coming in our arsenal more recently. We had antibody drug conjugate with brentuximab approved in 2011. It was almost at the same time where we had our first immunotherapy that we heard so much this morning about, ipilimumab. And more closer in time, we have the first BiTE with blinatumomab. And what also contributed to reshape furthermore the cancer care was the fact that we had those combining strategies of all those different treatment modalities that really changed the way that we're treating cancer. So with that, we're having more personalized options, but they also come with their load of complexity. At the beginning, around the 2000, we were used to treat with chemotherapy. We had really limited side effects. We were used to nausea, vomiting, bone marrow toxicity, and alopecia. So with these no drug, they are not chemotherapy. We don't have the big danger sign on it, but they're not minor because they're coming with a big load of toxicities that were new to the clinicians and also to the patient. Also, it has the complexity that the side effects vary widely depending on the target that we're affecting. This way, we have to come up with monitoring strategies and also management guidelines that are really specific for each target. Those side effects also, they develop sometimes slowly and they can persist over time, which also create challenges in following the patient. And it's not because we have a minor and a persistent side effects that we have to omit. It was already mentioned several times in the presentation of Dr. Assalé that it's a problem about the adhesion, the adherence to treatment. So it's important to take care of those side effects because it can really compromise the outcomes that the patient can get from their treatment. We also have the complexity of those combinations. When we're combining those drugs, often side effects overlap, and it becomes really difficult to identify the offender for the clinician. And this is where also the counseling of the patient is really important, because we know that by informing the patient, we can act earlier, and this way maybe improve the outcome of what we can get for those treatments. So in the 1990s, we had the shift in where with the ambulatory care shift, where all the patient was sent to the community. At that time, it was a good idea maybe for the patient in regards of access and convenience to send them to the community pharmacy to get their treatment. But we kind of forgot, maybe one of the blind side was that then we didn't have a regular contact with several team members like the nurses and the pharmacists, and they were sent to other professionals that are not specialists of the disease, and it makes it harder for them to follow them because the care are really, really complex. You need this kind of knowledge to be able to take care and act promptly when patients are facing issues. So the role of the healthcare professional in that decision was really not taken care of. And it's really important to highlight the specific role of supporting the patient throughout their treatment, being able to identify the side effects early, and also to be there, like the retail pharmacists, they are there daily, and they are available, like before Amanda came, they are still there to support the patient in their daily life. And it's important to reinforce this adherence and also to maximize the dosing and the intensity of the treatment if we want to make sure to optimize the outcome. Because it's good to have the data coming from clinical trial, but we really want to bring those results into the real life setting. And for that, we have to make sure that we're maintaining a good exposure to our patient and to their treatment. So where the idea came from. So when this big wave of TKI was hitting the market, it became really an issue and a preoccupation for the oncology stakeholders, because we were sending those patients to the community away from their oncologist. And it became a recurrent topic in the meetings and in the conference to see how the oncology pharmacists can help and support their community colleagues managing and following those patients. And we have also to take into consideration that in Quebec, we were maybe a bit lacking the leadership, like the governmental leadership like they had in BC or in Ontario, and to have structured resources to take care of patients. And back in the time, in the early 2000s, it was really clinician initiative that were trying to get together and develop some tools so in Quebec we can support our patients better. So with the support of the pharma, and also the project of OnTarget came from the leadership of 3 oncology pharmacists. The leader was Lucie Surprenant, who was a former pharmacist at St. Mary's. And also, we had, like I mentioned earlier, the support of the pharma in developing a tool. So I was recruited with 2 years of experience in oncology under my belt because of my former experience as a retail pharmacist. So I was a good person to understand the need of the field. So around a few glasses of wine, we reflected on the fact that the target that drives the efficacy often defines the toxicity, like it was mentioned several times this morning. So because it's reflecting of this on-target effect, we thought that by grouping the drugs by molecular target, we can help revealing the share and predictable toxicity pattern that comes with the target. Because most of the side effects, they are not idiosyncratic. They are really related to the role of the protein in the human body, because this protein is not just there to create cancer. It has a physiological role. So the on-target approach came that we wanted to turn the mechanistic understanding into a clearer toxicity anticipation, and we wanted to have more informed and more equipped pharmacists to help proactively prevent and manage adverse events in their patient population. So about the content, we already had some good resources available. We had Le GEOC, we had BC Cancer, and Vigilance. And also we have to think how we can maintain the information up to date. So we decided to really dedicate our project and focus on the practical management of adverse event and clinical support. So there were no resources that was actually reviewing the secondary literature coming from narrative review or practical clinical guidelines, and to put the information together at the same place and compare drugs within them so we can really have all the information accessible at a single place. We decided not to cover certain information. For example, drug interaction, we're just gonna, we just have a glimpse at it just because we feel that there are better resources for pharmacists. We have the software that are good references for that. Also, for posology, dose adjustment, or indication, there are already great resources around, and we didn't feel that there was an additional need in repeating this kind of information. For sure, chemotherapy agents are not covered because they were managed at that time by the hospital pharmacist. When ADC reached the market, we decided to leave it aside because they don't fit, especially the idea of treating or looking at specifically the target, because the effect is being a bit confused by the payload that is attached to your antibody. Also, at the beginning, our audience was aimed to be the retail pharmacists. So we decided not to discuss some side effects that were more commonly encountered in hospital, for example, infusion reaction. But the audience has shifted, and we have seen that there are many oncology pharmacists and nurses using the resources. Therefore, we have decided in the newer chapter to develop a bit more this kind of information. But you would see that there might be a bit of a discrepancy in between chapters about the content that you may find. So the OnTarget came to life in 2009 in the format of a PDF document with 16 drugs and 8 targets. We have updated twice in the format of the PDF in 2012 and 2015, and you can see that over that time we doubled the content that we had with 36 drugs and 15 targets. After the second update, Lucy decided to retire, and I inherited of the project. At that time, obviously the PDF format was outdated and wasn't answering the need, because the updates were not frequent enough. So it came obvious that we needed something that was more useful and that we can update a bit more easily. And also I have to mention that the pharmacists taking care of this project are doing it on their free time, nights and weekends, to update. So I surrounded myself with a new team of pharmacists from Maisonneuve-Rosemont and Le Chum. And in 2019, we launched the website, and we had at that time 53 drugs and 22 targets. Since that time, we are now up to 109 drugs, over 36 targets. I did not mention that we gave ourselves also the objective of providing continuing education to the pharmacists, because we felt that by providing quiz, it would help integrating the information that is available on the website. And since the beginning, we had granted more than 3,500 units showing that it's a tool that is well used. And we have about 1,000 users connecting every month to access the information on the website. So we can feel that despite the AI that is just around the corner, this kind of resources is still pertinent to the daily practice. So now that I explain you where it's coming from, I'm going to just navigate the website so you can see the kind of content that we have. When I prepared that slide, I was maybe a bit high on caffeine, so it's a bit hard to follow because I film my screen, so don't blink your eyes and just bear with me. So to access the website, you have to type ontargetonco.com in your browser. The website is available in French and in English. You have to register, but it's free, and you don't have to be a healthcare professional to register. Once you're registered, you can log in, and then you will be able to access the whole content. You can navigate the website either by drug class, drug name, or by using the search tool. I'm going to use the drug classes and the EGFR inhibitor class as an example of the information that you may find on the website. So chapters are always organized the same way. In the first section, the target, we're going to explain the physiological role of the protein and how cancer may develop by the dysregulation of this protein. Then, in the drug section, we're going to compare all the different drugs within them. So if it's a newer generation overcoming a mutation, we're going to mention it there. But it's really brief review, like it's just to give an overview. We don't go in deep details. We're always providing a schema explaining the pathway and the mechanism of action, which helps understanding the action of the drug and the side effects. In the drug administration section, we really have a brief information on how the medication is administered. In the interesting facts section, we're going to provide information that would help the pharmacist do the teaching. We can, for example, provide information about how food is impacting the absorption of a drug. We can also discuss certain drug interaction, even if I said that it's not the primary resources for that. For example, here we're going to explain how the PPI can affect the absorption of dacomitinib. And we're going to highlight some interaction that will not be captured with like the software. For example, smoking and erlotinib is reported there, while I'm not sure that we're going to detect it in vigilance. When to refer section is usually the content of the black box warning, and those are situations requiring immediate medical attention. The adverse event section, we're going to just give a general tolerability of the class. And in the table below, we will report side effects with an incidence of more than 10%. We may have different cutoff for certain classes that have a better tolerance rate. You will see that certain side effects are bold, so if you click on it, it's going to bring you to the management section. So here, I'm just going to explode the paronychia section to show you the kind of content that we have. So in the first paragraph, we're going to explain and compare the different drugs within them in regards of incidence and severity of the side effects. We're going to provide information about the onset and duration of the side effects, which is really useful in a teaching when patients are trying to understand what's going to happen to them. In the prevention section, we will provide any measures that can help the side effects to appear, and we always make sure to list products that are available on the Canadian market, and we're going to put the brand name to help the prescription and the recommendation. In the management section, we always separate guidelines that can be done over the counter or require a prescribed medication. In this section, we don't have it, but when there's special monitoring that can be done, we're going to add it in the table. In the key facts section, we're reporting information that were not captured in the different section, but we still feel is pertinent or relevant to understand a bit better the side effect. And I mentioned the continuing education being one of the missions we gave ourselves. So after several years of developing quiz per drug classes, last year we changed a bit the way we're doing things, and we developed modules on specific subjects that are going across the different drug classes. And it looks like this new format is highly appreciated by our users because we have been having a good feedback that they feel that the patient cases modules are really interesting to their practice. So I would like to do a few clinical cases to give you a better idea of how it can be used in the daily practice. So first, Emily, who doesn't know how to spell her name correctly. She's a 28 years old pharmacist working in Sherbrooke. So she's enjoying working as a pharmacist, and especially she's good with elderly patients. On her free time, Emily, she likes hiking on Mount Orford where she can do bird watching. And also she likes reading Louise Penny novel and listening to health podcasts. So yes, I have a conflict of interest to disclose in the creation of Emilie. So Emilie today is mating with Claire Salmon. So Claire, she's a 71 years old patient with pretty good health, aside from the fact that last year she got diagnosed with urothelial cancer, which was unfortunately already stage 4. At that time, she received enfortumab vedotin and pembrolizumab for 6 months. After a partial response, she progressed, and at that time, she was prescribed a second-line therapy with carboplatin gemcitabine, which did not work at all. Dr. Reynal did an NGS testing, and he found the FGFR3 mutation, for which he was happy to have a medication that he can prescribe, which is erdafitinib. So Emilie was a pretty good student at University of Montreal. So in her oncology class, she learned about the OnTarget website. So she's accessing the website just to get to know a bit more about the FGFR signaling pathway. So by accessing the target section, she's learning that there are 4 tyrosine kinase part of the family, and that they are activated by FGF ligands, which induce a receptor dimerization and activating the kinase signaling pathway. The pathways that are activated are the MAP pathway as well as the PI3K. The physiologic role of the FGFR receptor is in embryonic development, tissue repair, metabolism, and angiogenesis. It gets dysregulated through gene amplification, mutation, and fusion. The oncogenic effect will drive tumor cell survival, proliferation, migration, and angiogenesis. The prevalence in cancer is 7%, but it's highly reported in urothelial cancer as well as in cholangiocarcinoma. And in bladder cancer, we find frequently FGFR3 mutation as well as FGFR2/3 fusion. About the inhibitors, which is the next section of the website, Emilie's learning that by blocking the FGFR dimerization and therefore blocking the activation of the downstream signaling pathways, it's going to induce tumor cell death. There are 2 agents part of that class, and the dose is the usage is limited by the on-target toxicity of the drugs. She's also learning that erdafitinib is a selective inhibitors of the FGFR 1 to 4, but it's approved only for the FGFR3 mutation. Specifically about erdafitinib, on the website, she will learn that it's an oral medication, but Emilie is surprised to see that the dose of erdafitinib needs to be adjusted based on the serum phosphate level. Here, she noticed that she will have to look into the drug interaction for her patient. And she's noticing that vascular thrombosis and skin necrosis are conditions that will require immediate medical attention. So intrigued by the role in the phosphate, she's exploring the management section about it. And in this section, she's learning that the incidence is pretty high, with 76% of patients presenting some kind of phosphate disorder during their treatment, but most of the time it's going to be mild to moderate and rarely severe. The onset is about 3 weeks. The phosphate level will usually spike after 6 weeks, and it will slowly decline over 5 to 6 months. The mechanism is that the FGFR inhibitor impact the renal phosphate reabsorption and plays on the vitamin D level. About the monitoring, by looking at this section, Emilie's learning that we should do baseline level, repeat it after 14 days, and then do it monthly. In the prevention section, Emilie is really happy that there's a lot of information that she can provide a patient with on how, like about food that she can favor or avoid in order to help balancing her phosphate level. And in the management section, she's taking a note that she can always refer back to that if like 30% of a certain patient getting FGFR inhibitors will require phosphate binder therapy. Rarely, those interruptions will be needed, but not so rarely, about 25% of patients will need it, but those reductions are less common. It's also important to know that hypophosphatemia can happen due to overcorrection. So with this kind of information, Emily has everything to console a patient and also to establish a plan of follow-up and be confident in following Claire. My next case, now we'll be working with Jason. So Jason is a 50-year-old community pharmacy in NDG. He has been working there for the last 25 years. Over the years, he was adapting to the new pharmacist practice, which was prescribing for minor condition, adjusting therapy, and also vaccinate patient. He's enjoying being a mentor to his fellow and younger pharmacist colleagues. Jason's going to do his first Ironman this year, so you can easily, or in the morning, find him biking up the Camillien Hood path, or running along the Lachine Canal, or swimming in the Westmont Park pool in order to get ready for his Ironman. So Jason has been knowing Maureen Roberts for several years because Maureen has been a client of his pharmacist for several years. She's enjoying training like Jason, and she has a pretty good health. Unfortunately, in 2022, she got a diagnosis of breast cancer. She was treated with surgery and radiotherapy and received after hormone therapy for 3 years. Unfortunately, in April, she got a bad news that she now has bone metastases. Her doctor, Dr. Ferrari, it has nothing to do with Le Grand Prix that we have this weekend. He's always at cutting edge of therapy, so he did an NGS testing on her sample, and he found a PIK3CA mutation. And since he's always pushing for the best therapy, he wanted to offer the triple combination with inavolisib, palbociclib, and fulvestrant. And Maureen was lucky enough to have her private insurance covering the treatment. So it has been a month that Maureen is on treatment, and she's coming today or this week to renew her treatment. So Jason is a diligent pharmacist. He's looking at the DSQ before renewing the medication, and he's noticing here 2 abnormalities in the fasting glucose and in the neutrophil counts. So what can he do about that, aside from calling AI? So by accessing the OnTarget website, he's going to learn that neutropenia is pretty common with palbociclib, with about 80% of patients developing these side effects. The good news is that it's generally reversible and rarely complicated, with less than 2% of patients developing some febrile neutropenia. Onset is pretty fast, in 2 weeks, and the resolution is also fast, in 7 days. In regards of monitoring, it's recommended to do a CBC at the beginning of each cycle and on day 15 for the first 2 cycles. For the management, we have to do dose modification in case of moderate or severe neutropenia, but fortunately, this is not the case of Maureen today. In regards of hyperglycemia, in the PI3K chapters, there's a lot to learn for Jason. So he's learning that the hyperglycemia is a non-target effect of the PIK3K alpha inhibition, which is playing a key role in the insulin signaling and as well as in the glucose homeostasis. The incidence is really high, with 60 to 65% of patients developing hyperglycemia. The good thing is that the severity is less with inavolisib compared to other drugs from the same class, but we have to watch for ketoacidosis because fatal cases have been reported in clinical trial. Timing is early of the side effects. We can see it in the first 7 days, so this is why it's recommended to have an early monitoring with a baseline fasting glucose and glycated hemoglobin every 3 days for the first week, then weekly, then biweekly, and then monthly. We can consider home glucometers or metformin prophylaxis for patients at risk. And we always have to make sure to optimize the glycemia before considering the treatment. The good news is that it's generally manageable, but it often requires medication for that. Certain patients will need a dose interruption, but rarely we have to stop or reduce the dose because of these side effects. So the follow-up and the plan that Jason can establish with confidence is that he can continue palbociclib despite the neutropenia, but Maureen will have to do a CBC on cycle 2, day 15. And Jason's going to advise Maureen to monitor signs of infection. In regards of the hyperglycemia, inavolisib can be continued at the same dose, but fasting glucose will need to be done every 2 weeks, and if it aggravates, we have to do more frequent monitoring. Glycated hemoglobin is required prior to cycle 4, and again, Jason's going to provide teaching to Maureen about the signs of hyperglycemia that she has to look for. So it's a pretty busy day, but the last case we'll have is with Susan. So Suzanne is in infirmière cadre in her center in the West Island that I'm not going to name. She's enjoying her role because she likes developing tools and supporting her colleagues when new therapies are coming. To release pressure, Suzanne likes to do dragon boat with the Pointe-Claire Canoe Club at night after work. So Dr. Long is meeting with Suzanne today to discuss the case of Mark Johnson. So Mark was diagnosed in 2024 with extended stage small cell lung cancer, for which he was treated with first-line durvalumab CVP, followed by a maintenance of durvalumab. Disease responded really, really well, but came back rapidly. He was retreated with CVP, and he was progressing again in November. So Dr. Long feels that he has a really short window to offer tarlatamab to his patient. So he's coming to Susan because he wants to start treatment right away. The nursing team are a bit concerned about the CRS that are reported with this class of agent because they heard of really dramatic cases in the hematologic field. So by looking at the website, it's good to know that the occurrence is pretty high, but the majority of the CRS is grade 1 or 2, with less than 2% that were life-threatening complication in clinical trials. And no fatal adverse event have been reported in those pivotal trials. Susan is really happy to have a list of symptoms that she will have to watch for and to teach her nursing team about. The median of onset is about 15 hours, so it can help setting the organization of the clinic to make sure that the good people will be there to monitor the patient. And she's relieved to see that the occurrence of the CRS is most frequent after the first dose at 43%, and it's going to slowly decrease, like patient will be less at risk in the subsequent doses, despite the fact that they will be receiving higher doses of tarlatamab. Susan is also happy to have a really detailed management section, so this way she can provide a tool to her nursing team without spending too much time digging around and asking colleagues for other references. So with a few clicks, she was able to gather all the information and teach her nursing colleagues about the side effects. So that is concluding like the different patient cases that I wanted to discuss. So why do I feel that OnTarget is pertinent even at this time of AI? We feel that by gathering all the information together, reviewing the secondary literature and crunching it, we can increase the knowledge of the healthcare workers, which will provide a greater confidence in counseling patients and managing their side effects. And we also feel that by improving the patient understanding, we will also improve the outcomes by having an earlier intervention for adverse event. We also feel that this tool helps providing consistency of care, especially when the care is being split between the hospital and the community setting. So that's concluding my presentation on OnTarget. So just as a curiosity, how many of you knew the website before my presentation? Okay, not so bad. And how many doctors are now planning consulting it in their daily practice? Dr. Miller, please. Thank you.